Good morning from New Jersey. This is Dr. Nick Tulo with my Saturday morning clinical live stream. Thank you so much if you're tuning in live. That's really terrific. And please feel free to put some comments up there. Good morning to everybody. If you're watching this later on, that's great. You can still learn a lot of stuff. But it was 18 degrees this morning in New Jersey. So I don't know about you guys, but I was pretty chilly. And anyway, we are going to talk about AV block today. If you're come to watch this live stream, it's going to be a fun discussion about AV block and some of the misconceptions that people have when they look at a cardiogram and have to interpret what degree of AV block is. Most people think they know. Good morning, Ricardo. So glad to see you again. Osmond, Leonardo, Brian, thank you very much for joining me. I'm trying to get better at looking at the comments. But if I don't see it, just throw something at the screen. I'm sure that'll work. Anyway, most people think they know what AV block is because they've read a basic text and they know about Mobitz WHO and Mobitz WHO and all that. But we're going to dive a little bit deeper into that kind of a thing. And by the way, I try not to use Mobitz. It's really better to talk about type 1 and type 2 when we're dealing with second degree AV block. So anyway, this is good morning, Kathy and Wyatt. And Richard, thank you very much for joining me. And this is so cool. Anyway, this is my 16th one now, so I guess I'm a little bit more comfortable. But for those of you who don't know, I'm a cardiac electrophysiologist, and so I deal in the world of ECGs all day. And I created ECG Academy to get people to think about the physiology and to try to understand ECGs so that they could become experts. I want you guys to be a resource at your hospital or in your medical practice and be super comfortable with making diagnoses and be able to look at a cardiogram. And good morning to all of you. And be confident about what you're looking at and be able to even argue. Sometimes you have to argue with the cardiologist, don't you? Don't you hate that? When you look at a strip and you think, oh, well, Dr. Nick said this and that, and now I'm looking at this and this, I'm sure that that's what it is. And the cardiologist looks at it and he says, what's wrong with you? You need to go back to school. And it makes you feel awful, doesn't it? But cardiologists really shouldn't do that. And in fact, I have a whole bunch of strips that were overread, ECGs that were confirmed by the cardiologist, and it's all wrong. So, everybody can make mistakes, but don't let them get you down. You make sure you know what you're talking about, and we'll be fine. Okay, so let's talk about a case, all right? Let's talk about a 60-year-old gentleman who goes to his doctor, and it turns out he has hypertension. Yeah, his blood pressure is, 165 over 95. And the doctor decides, well, beta blockers might work for this guy. He's type A, so he puts him on Toprol XL, metoprolol, long-acting, 50 milligrams a day, let's just say. How many people would do that? Raise your hand. Let me see. Can I see him? Now, well, see, conventional beta blockers, the current wisdom is that they're not really good for hypertension. Certainly not as monotherapy. I tried to avoid conventional beta blockers. Why? Because they reduce contractility and they reduce heart rate, right? But then the heart has to pump more blood with each beat. And then as a side effect, because they're beta blockers, that means you get unopposed alpha at the periphery. Why is that so important? Remember your basic physiology. In the periphery, you have catecholaminergic sympathetic receptors, which are beta 1 and beta 2, but you also have alpha receptors. And in the periphery, the alpha constrict and the beta dilate. Well, if you're blocking the receptors that dilate the blood vessels, you get unopposed alpha, which causes constriction. So what does that do to patients? It gives them cold hands and feet. They get Raynaud's syndrome, and the blood pressure doesn't really drop well. I mean, it just... Well, I try to avoid using beta blockers as a first-line therapy, unless you use a beta blocker that has some alpha blocking capabilities like carvedilol or Coreg. and bystolic also has some of that. So not really alpha blocking, but it does other things that makes bystolic better for hypertension. Okay, so didn't work, right? So now the doctor says, well, okay, let's try a calcium blocker. We'll put him on cardizem. So he prescribes cardizem CD 240 milligrams a day. And then the patient comes back for follow-up, and his blood pressure is better, but his heart rate's a little slow. So what does the ECG show? Good morning, Jerry. So here's, let's take a look at the ECG. Okay, you guys should be able to see that now. And yes, the heart rate's a little bit slow. It's about 45 or so beats per minute. But it's regular. And let's see if we can pick the right tool. Yes, I should have done this before, but I didn't. Sorry about that. So now I should be able to draw on this. Yes, okay, that's fine. So, okay, so you see these QRSs are pretty regular and very slow. And when you see bradycardia, there's one of two things that's happening, right? All right, it's either sinus node failure or AV block. And what you need to do is look at the P waves really carefully and figure out what the sinus node is doing. And if you have any experience in ECGs, you should be able to see that the P wave, the atrial rate here, is twice as fast as the ventricular rate, right? So, and now you look at the PR interval, and it's a little bit long. Yes, it's a little bit long. It's about 280 milliseconds or thereabouts. I always, people always, when they do ECG Academy, they always say to me, how can I, put my calipers on the screen to kind of measure? Because, they're used to the courses in the hospital that said, well, measure the PR interval and you have to be da-da-da-da-da. Well, it's the number isn't always as important as the idea. I mean, you can measure, but if it's 240 or 260, it's not that much, it's not that important. But I just want you to get the idea, the concept. Yes, why it is 2-to-1 conduction. And because the PR intervals are stable, the assumption is that every other P wave is blocking, and so you have 2-to-1 conduction. And notice that the rest of the ECG is sort of unremarkable. The QRS is pretty narrow. You have poor R wave progression, but I don't know, in my hospital, I don't know about your hospital, but in the emergency room, and a lot of times they just put V3 in the wrong spot, right? V3 should be between V2 and V4, right? And it should be like halfway in, but some people put V3 too low on the chest wall. That's a whole nother story. But that's why sometimes the V3 R wave looks too small. Let me just make sure I got this in the right magnification. Okay, so we have 2-to-1 block. So if you had to give this a diagnosis, would you call it first degree, second degree, third degree, right? That's easy, right? Remember the difference. In first degree AV block, every P wave conducts. It's just the PR interval is longer than 200 milliseconds. In third degree AV block, none of the P waves conduct. So your atrial rate's faster than your ventricular rate. Your ventricular rhythm is an escape rhythm, and so it's regular. It should be perfectly regular and honestly slow. And sometimes it's narrow QRS, and you can call it a junctional escape because it's running at a rate of 40 to 50. Sometimes it's a wider QRS complex at lower rates like 30 to 40. Then you can call it an idioventricular escape. For those beginners, I hope I'm not kind of going over your head, but these clinical live streams are for people who are in the medical field, who are dealing with ECGs all the time and want to get that really keen appreciation for the nuances, the subtleties of electrocardiography. So Wyatt's got it. Wyatt, good job. High grade AV block. It's second degree, which is some of the P waves conduct. So you have first degree where none of the P waves, first degree where all the P waves conduct, third degree where none of the P waves conduct, second degree, some of the P waves conduct, and then you have type 1, type 2, and high grade, So what do we mean by high grade? High grade means 2 to 1, 3 to 1, 4 to 1, where some of the P waves are still conducting, but at least every other P wave gets dropped. Okay, so that's kind of a hard concept for people to understand because of this. Good morning, Tex Lager. Nice to have you. Thanks for joining us. So here's the idea. A lot of people will look at this and call it Mobitz WHO. They say, oh, I know what this is, Doc. It's Mobitz WHO. And this is a misconception that has been perpetuated by interns and residents, and even attending physicians will sometimes call it. Some of my partners will even make this mistake. By calling it Mobitz WHO, you are labeling this incorrectly, because by definition, Mobitz WHO has a fixed PR interval, and then suddenly a P wave is dropped. But in order to be able to say whether you have Mobitz 1 or Mobitz 2 or type 1 or type 2, you have to see, Missy from Malaysia, thank you. Do you treat 2 to 1 block differently than Mobitz 2? That's the whole point, Kaiman. That is why we're here today, is to understand why 2 to 1 block can be one of two different things and how to figure this out. So 2 to 1, so 2 to 1 block is not Mobitz 2, okay? 2 to 1 block is in a separate category known as high grade AV block. And here's what we're talking about. Okay, so let's kind of go up here to my little drawing of the conduction system to kind of get to be able to understand. Nicola, thank you from the UK. Hello, it's so good to see you this morning. All right then, so you've got your atria and your ventricles here. You can see this, can't you? All right, so you've got the sinus node on the top. I don't know what part of England is. I have a lot of different English accents, but when I do them in front of a real English person, they look at me and they go, oh, no, stop, please stop. So anyway, sinus node fires and the signal goes across the atria, and here's where this gets a little complicated. The AV node is designed to obviously receive the signals and pass them down to the Purkinje system and to the ventricles. Okay, but the sinus nodal and AV nodal tissues behave differently, and it has to do with the action potential. So let me bring up this thingy here. These are all my action potentials for the cardiac tissues. So for the various cardiac tissues, you have different action potentials. So the one we are used to seeing is a ventricular muscle tissue. If you look at that, let me just make my brush a little thinner. So you have phase 0. Oop, hello. What happened to it? Oh, I know. I have to be drawing on the right. Okay, so phase 0, which is when sodium rushes into the cell rapidly, causes rapid depolarization. So normally inside the cell you have a lot of potassium and just a little bit of sodium. Most of the sodium is outside the cell, right? So because when you do a BMP, you get sodium levels in the serum of 135, you get potassium levels in the serum of 4.5. Right? Because all the potassium is inside the cell. So during depolarization, phase 0, sodium rushes into the cell because of the sodium channels in the cell membrane open up. And God, I can talk for hours about this. I know you guys are like, oh, I thought I didn't have to think about this after I passed the test. Okay, so anyway, so sodium rushes into the cell, making the inside of the cell more positive, so you get this rapid upstroke, and then you have a plateau phase, and there's lots of sodium and potassium movement during the plateau phase and calcium and stuff like that. But just to simplify it, repolarization occurs when potassium rushes out of the cell and restores the normal resting membrane potential. Oxford. Oh, thank you. You recognized my accent. It's from Oxford. Thank you. All right. So, okay, where was I? The thing is that the pacemaker tissues, the AV node and the sinus node, don't have rapid sodium channels in the cell membrane. And so they depolarize because of calcium that moves slowly into the cells through slower calcium channels. And so here's your AV node or AV nodal cell, and you notice the depolarization is much more slow and then the repolarization occurs more slowly. So it's a whole different behavior of the cell, and that's why AV nodal cells behave differently than sodium dependent. So AV node is known as calcium dependent, and all the rest of them, including the atrial muscle, the Purkinje fibers, the His bundle, and the ventricular myocardial cell, they're known as sodium dependent. The difference is this: at faster rates, the refractory period of sodium dependent tissues gets shorter. Okay, the action potential shortens and the refractory period shortens, and so sodium dependent tissues are able to conduct more rapidly. Not in terms of velocity, but in terms of how many beats per minute they can comfortably conduct. On the other hand, calcium-dependent tissues like the AV node and the sinus node, the faster you stimulate them, the worse they conduct. So premature beats get slowed by AV nodal tissues. That's why if you have a PAC, sometimes you'll conduct with a first-degree AV block. So the idea is you get delay within the AV node. If your atrial rate is too fast, you get delay. So that's why at faster rates, the PR gets longer. Now, if your AV node doesn't work well at all and you're unable to conduct one-to-one at a particular atrial rate, AV nodal conduction will occur so that you'll get progressive delay of the signals until one is finally blocked. And that's what gives you that typical winky back periodicity where the PR gets longer and then sometimes even longer still, and then you'll block a beat, and then the PR gets shorter again. So that changing PR interval, that prolongation of the PR interval, that decremental conduction is what we call it, indicates that you're dealing with delay within the AV node itself. On the other hand, I'm sure you remember this from physiology, the His bundle and the Purkinje fibers, the sodium-dependent tissues, don't generally, under normal circumstances, exhibit decremental conduction. They either conduct or they don't conduct. So you get that all or none kind of phenomenon. And so when you see type 2 AV block, where your PR interval is fixed, and then suddenly you drop a beat, and the next PR interval is the same as it was before, that's the pattern known as type 2 or Mobitz WHO. And that, what does that indicate? It indicates that the level of the block is more likely down in the lower part of the conduction system, below the AV node. So in the His bundle and the bundle branches, you could have trifascicular conduction system disease, or you can have disease in the main bundle of His. And that causes this sudden failure of AV conduction with no preceding prolongation of the PR interval. Does that make sense? Okay, I go over this in my AV nodal section in ECG Academy, but this is something that a lot of people don't think about, because by looking at the pattern of the PR prolongation, whether it's prolonging or not, you can tell the level of the block. Is it blocking in the AV node itself? Or is it blocking below the AV node in the infranodal tissues, the His bundle and the Purkinje fibers, right? So that's why it's so important. Well, why is that important? It's a good question. Okay, Ricardo, you can explain it to me, okay? So the problem is that if you have an AV block, and if it's in the AV node, sorry, sometimes I do these crazy voices, but if you have AV block, here, let me just do this. So let's say your AV node is the culprit. And if that AV block progresses and becomes complete, well, then usually you'll have a reasonably adequate escape rhythm that arises from the AV junction, or sometimes even the His bundle or one of the hemi bundles. So you'll have an escape rhythm that maybe at 30 or 40 or whatever beats per minute, that's certainly adequate enough for the patient to not die suddenly. The problem is that if you have trifascicular conduction system disease, and by the way, I did go over this in my live stream on trifascicular block, so you can actually go back and watch that one. If you have trifascicular conduction system disease and it fails completely, you may not have an escape rhythm. And that's where you can have problems with syncope and even sudden death, because what you get basically are just P waves that march through and they're not going anywhere and you have no escape rhythm. So I have plenty of ECGs like that to share. But that's why the level of the block is so important. Now, how are you going to figure out the level of the block? Well, type 1 suggests that the level of the block is in the AV node or intranodal or suprahischian. That's another way of putting it. And so it's not as serious as block below the AV node. Now, one of the clues is that if you have block below the AV node, if you have serious trifascicular conduction system disease, often you'll see a wider QRS complex. You'll have bundle branch blocks. That gives you sort of a clue that you're dealing with disease below the AV node. So anyway, let me show you some interesting cardiograms. So anyway, with this patient, so this is a case presentation, right? So with this patient, we're 21 minutes into this. Wow, that's cool. So with this patient, was it the medications that caused the AV block? I mean, so if we stop the cardizem and switch them to Coreg, is the AV block going to get better? Well, it all depends on whether the medications are causing the AV node to slow down, or whether the patient happens to have developed infranodal disease, trifascicular block, His bundle failure, and if you stop the medications, it's not going to make a difference. So, I mean, do you call 911 and have that guy whisked off to the hospital in an ambulance? Well, he feels fine. So, but you have to basically make a decision whether you think that this was medication-induced intranodal block or not. And if you have 2 to 1, you can't tell. That's the point of this whole thing. So let me show you an interesting cardiogram. Okay, so here is a person, similar. You have the same kind of narrow QRS complex, and you have the same type of 2 to 1 block. Here it conducts, and then it blocks, and here it conducts, and then it blocks. But notice something. With this ECG, this beat conducts, and then this one conducts also. But what happened to the PR interval? Aha! It got longer, and then finally this one blocks, and then you're back to 2 to 1. So this proves my point that just because you have 2 to 1 doesn't mean it's Mobitz 2. And it doesn't mean that it's infranodal. You can't really tell. So in this case, it now becomes obvious because you have 2 PR intervals in a row, so that you can now tell that the PR is getting longer prior to dropping a beat. And so this tells you, number one, that the block is likely high up in the AV conduction system. And number two, if you stop the medications, it's likely going to get better. Okay, that's what's cool. Now, maybe you'll get lucky and you'll see something like this on a cardiogram in the office, or maybe you have to do a Holter to kind of catch something like this, because it's a matter of what the atrial rate is. As the atrial rate slows down, you might see more of this because the AV node doesn't get blocked up as much. Because the faster the atrial rate is, the more likely the AV node will block. Everybody get that? Okay, but now here's another example of a cardiogram, and I got both of these in the same week. So here's another example, and this actually goes to Tulow's law. Look at what the computer read this cardiogram up here, up at the top here. It says sinus rhythm with premature atrial complexes. And I'm not sure if the cardiologist actually picked that up or not, but that's what's happening. Is here you have short intervals and longer ones and shorters and long, and then for a while it gets really just consistently long, and then you have a shorter one again. So what the computer saw this pattern, it's mostly steady, but every now and then you get a premature beat. But what are the P waves doing? So now if you look up at V1, which is a really good place to look for P waves, you can see that the atrial rate here is about 80 beats per minute. and you have 2-to-1 block that's occurring during most of this tracing, but every now and then you have 2 P waves in a row that conduct, like this one and this one. And as far as I'm concerned, that PR interval is pretty well fixed. There's no change in the PR interval when you have these beats that are conducting. The other thing that you can do is measure the R to R interval. And if it's type 2 AV block, the R to R intervals will sort of fit into a fixed interval. So the length of the pause will be exactly 2 times the R to R interval where they conduct. So that tells you that this is type 2. Not only that, but look at V1. What do you have? That RSR prime, what does that tell you? So it's a right bundle branch block. So you have a right bundle branch block. You also have a left axis deviation. Doesn't quite meet the criteria for a hemi block. But the point is that that right bundle branch block is sort of a clue that the disease is below the His bundle, and that this is type 2 with periods of high grade 2-to-1 AV block, whereas the other ECG is really kind of, this ECG is going to be high grade AV block with periods of type 1. So, and like I said, it's the atrial rate is going to determine how much of the cardiogram is going to be 3-to-2 and how much of it is going to be 2-to-1. So this I just want you to understand that 2-to-1 doesn't tell you where the level of the block is, and that's the important part. Think about the physiology. How does the AV node behave? How does the His bundle behave? How can we figure out where the level of the block is? Because if you have type 2, true type 2, second degree AV block, then those patients really should get a pacemaker, because their degree of conduction system is serious enough that that if it gets any worse, they can wind up getting into big trouble with no escape rhythm. And those are the patients that wind up with serious symptoms. And so those are the patients who should get a permanent pacemaker, the ones with type 2. The ones with type 1, at least in the States, generally you're looking for symptoms. So, because sometimes people can get type 1 second degree AV block when they're asleep because of high vagal tone. Sometimes if their atrial rate gets too fast, they can have a little bit of wanky back, but the ventricular rate remains reasonable and they don't have any symptoms. And in those cases, a pacemaker isn't really going to make a difference in their symptoms, and it's not going to affect their prognosis. So we generally hold off on recommending a pacemaker in type 1 second degree AV block without any symptoms. So that's the difference. If you see that, if you decide that the level of the block is infranodal, it's time to schedule a pacemaker. If you believe it's supranodal, then the medical interventions like beta blockers and verapamil and diltiazem, they can affect AV conduction. If you withdraw those medications, then chances are the AV conduction will improve and the patient won't need a pacemaker. So I hope that kind of gives you some insight into how I look at ECGs and how I treat patients with AV block, because it really makes a big difference in how the patients get treated, and who gets a pacemaker and who doesn't. And ultimately, that's what you want to do, is make the right choices and the right therapeutic recommendations when you have patients with this kind of complex arrhythmia. So thanks, Tech Slacker. I'm glad that you found it to be useful. Thanks, Christian, for tuning in. I really appreciate it. If a patient has AP, if a patient has symptoms with wanky back, and it's irreversible, and there's no secondary reason for it. In other words, if you're on diltiazem for hypertension and you get wanky back, well, Could you switch to something like amlodipine, which has less effect on the conduction system? So you can switch to a drug that won't have the same effect on the conduction system and get away with it. Get away without a pacemaker, because at that point the winky back will improve, patient's symptoms will get better. However, if you have conduction system disease, if you have AV nodal disease, and you have symptoms because of bradycardia, then a pacemaker is appropriate. Jerry, thanks for tuning in. Osmond, I'm glad you found it helpful. Wyatt, thanks again for tuning in. And until next week, this is Dr. Nick Tulo with the ECG Academy. Don't forget, subscribe down below. Click on the link and subscribe so you'll get notification, and let all your friends know. Let them know that they can watch these things online. Try to do it every Saturday morning. And until next week, have a great day, and happy ECGs. Thanks.